Are you going to pick up? Are you going to pick up something? That's good. Okay, great. Perfect. Okay. Thanks very much, everybody. A couple of folks online and folks in the room, and there's usually a few more that wander in as we get underway. So, yeah, grab something to eat. My name is Norm Buckley. Dr. Zacharias wasn't able to be here for round, so he handed off the introductory responsibilities. We'll see what we can do. But the business of sleep and pain is quite critical, and it's actually fascinating stuff. And anesthesiologists think that they understand something about sleep because we can induce something that looks like sleep, but actually we don't know anything about normal sleep because we create drug-induced comas, and that's different from normal sleep. But we do watch it, and we're particularly concerned with awareness. And in the pain world, the interaction between sleep and pain is fascinating, and in many of the patients we see who've had accidents or assaults as the underlying cause of their pain, some of the other things that happen, like nightmares and so on, also complicate the business of pain and sleep. So we're fortunate today to have somebody who actually works in what I think is the greatest named place I've ever heard of, the Center for Sleep and Chronobiology. So that was fascinating. She's a graduate of McMaster, and after studying neurosurgery for a while, realized that her true way to understanding lay in psychiatry. And so she pursued her residency in psychiatry here at McMaster and graduated about 10 years ago. She's a sleep medicine specialist and psychiatrist, and founded this Sleep-Wake Awareness Program, or SWAP, as part of her work in the Center for Sleep and Chronobiology in Toronto, and has authored a number of works, as well as creating novel scientific material and clinical activity, clinical treatment programs. So I'm very much looking forward to this discussion. Dr. Thirlwell, thanks for coming.
Thank you. Can you hear me from here, or do I need to step closer? This is good? A bit closer? So thank you for the introduction. I have to say that I am always eternally grateful to McMaster that had the breadth and flexibility that really attracted my type of mind. My passion has always been neuroscience, ranging from Wilder Penfield, which you were just talking about, and then some of the early sleep doctors who were looking at dreams. And how does it all come together? And I knew that when I was finishing psychiatry, I wanted to do PTSD, pain, and the one area that brought that under an umbrella was sleep. And so just in terms of disclosures, I am currently working the educational grants with MedRelief and Tilray, who are licensed producers. I've been working intensively with veterans for close to 2 years now. I've been treating veterans from across the country, and that's where this presentation really gestates out of, is the crossroads between insomnia, PTSD, and chronic pain, because that's what we're talking about when I'm talking with them. And really, the link that I'm growing to appreciate more and more is autonomic dysregulation. And that's a common vocabulary that can cut across all modalities and many specialities. And I just want to bring your attention back to that, and then hopefully give you some specific tools that you can bring back to your practice and sort of see your patients from a broader lens, or another shifted lens. Are there any burning questions that people had, or specific areas they want me to focus on in particular, interests they want me to focus on in particular during this hour? No? Well, if they come up as we go along, just raise your hand, and then I'm happy to answer, because we can take this all over neuroscience if we need to, from in the petri dish to psychiatry. So in the last 2 years, as I said, I've been treating veterans a lot, and many first responders as well. I have firemen, people who work in ambulance, first responder lines, the people who work on 911. And the three sort of novel modalities that I have been exposed to and who have been learning through my patients about their clinical response to these modalities are medical cannabis, electromagnetic frequency modalities of pulse electromagnetic field therapy, or PEMF, and low-intensity laser therapy, or LILT. Who is familiar at all with any of the radio frequency modalities? A little bit? Yeah. That's why I want to come back to McMaster and really have a chance to expose researchers and clinicians to these modalities because they are incredibly effective. In working with the laser, the LILT, I had, in all my time in my neurosurgery training, I had never seen responses to pain management that were so dramatic. And over the last 2 years, I've also seen that with medical cannabis, in which my veterans now are able to get out and walking and be functional rather than being isolated at home with many, many, many side effects from polypharmacy. So the educational objectives today, as I indicated, is we're going to look at autonomic dysregulation and how that presents in actual sleep studies and objective sleep data in the form of insomnia, non-restorative sleep, and its effects on the inflammatory system, the endocrine system, physical pain, and mental health. And yes, there is a bidirectional relationship between sleep and pain. So, you know, the patient says, oh, the pain woke me up all night, but actually as well, poor quality sleep over a long duration can make pain worse. Then we'll go into the theory of autonomic dysregulation presented by Stephen Porges, which looks at the sympathetic, parasympathetic nervous system and attachment, or the degree to which you feel safe and you can function from your frontal lobe. And again, the modalities I've been working with, and then a few cases to illustrate those. Now, the clinical importance of sleep. I first got exposed to sleep, was here in a tertiary mood clinic with refractory depressive patients who weren't responding to antidepressants, and the doctor I work with, Dr. Martin, sent everybody for a sleep study. And then when I was looking at obstructive sleep apnea, it was many of the problems that we had listed with depression, cognitive processing problems, memory consolidation. But the other aspects of sleep is pain regulation. It affects the endocrine system. Definitely there's an increase of inflammatory factors released. And there's a difference between sleep quantity and sleep quality. Your patients might be sleeping 8-10 hours a day, but it doesn't mean they're getting quality sleep. In fact, if they're sleeping 10 hours a day, likely is they're not getting a deep quality sleep. I had the good fortune of being trained after I finished my residency here in psychiatry by Dr. Harvey Moldovsky, who was one of the grandfathers of sleep medicine and who looked at fibrositis in 1975, but now that would be labeled fibromyalgia. And he identified objective markers in sleep studies that are related to autonomic instability, or we call it sleep instability in the sleep world, that were precursors to the development of these chronic aches and pains in the body. And in this one study, he had healthy university students sleep deprive them for 3 nights and 3 days. A few of us went through that, maybe somewhere in our training before Pero protected everybody. They developed the aches and pains of some of the fibromyalgia patients. He restituted their sleeps and the pains went away. And he was doing some very interesting research with NASA and the Russian cosmonauts as well. So that's the pain piece. Then let's look at the PTSD piece. We have insomnia, nightmares, sleep-disordered breathing, periodic leg movements, dream enactment, night sweats. A lot of this is intertwined with increased sympathetic nervous tone and the autonomic dysregulation, and as well as this. These are all sort of how PTSD is divided into its categories in the DSM, but a lot of them play into increased sympathetic nervous tone, flashbacks, avoidance, mood changes, arousals. And here is a model of the hyperarousal hypothesis to do with emotional and physiological aspects of insomnia. And Basta and al. Were the first people to really talk about the increase in cortisol levels in people with insomnia. So these are the low total sleep time patients, and they have increased release of cortisol, which makes sense. Also, Basta and al. Also looked at inflammatory markers, IL-6 and tumor necrosis factor A, and in the insomniacs on the top, there is also an increased release of these factors. So I don't know about you, but in medical school and residency, sleep was 1/2 afternoon. And we learned that sleep goes from wake to stage 1, stage 2, stage 3, which is deep sleep, then into REM where you dream, and down like this. And they don't really know exactly what all the stages do. They know it involves memory consolidation. Some people think it also has to do with packaging of cell membranes. But the thing is you need equal proportions of all those stages throughout the night to get equal sleep. When you have autonomic dysregulation, you have an interference pattern that runs across that nice sine wave. So if you imagine part of your brain is trying to do the sine wave and sleep deeply and get deep sleep and have REM and restore the body, the sympathetic drive comes in and rides on top and goes, wake up, wake up, wake up, wake up, wake up. So that's like someone poking you all night long. How are you gonna feel in the morning? How will our patients feel in the morning? Fatigue. I don't know what the problem is, doctor. I slept, but I'm never refreshed when I wake up in the morning. Another big piece that you want to understand with your patients is the difference between sleepiness and fatigue. So if they say, I'm tired, then ask, are you sleepy, which is an uncontrollable urge to fall asleep, and then you're thinking about this list of differentials, versus fatigue, which is an aspect of non-restorative sleep where they have autonomic instability interfering with their sine sleep wave, and they're having these issues of PTSD, medications that are dysregulating their autonomic nervous system. They have a history of head trauma or chronic pain, chronic disease. This is what your differential that you're thinking of with fatigue. Many patients have both. So I can treat sleep apnea and still find fatigue is there, and they'll say, oh, the CPAP machine is not working. It's not working for me. It's working. It's treating the sleep apnea, and it's helping your oxygenation remain at a good level post-op, but we're not treating the glitchy brain, that I call it, sort of like a light switch that you're trying to turn off, but it keeps on popping back on. That's the sympathetic hyperdrive. So autonomic dysregulation presents itself as non-restorative sleep, daytime fatigue, some musculoskeletal pain, so that's the increased inflammation. So the inflammatory factors go, of course, throughout the body, hit the ends of the neurons, and throughout the fascia, and then you have this aches and pain feeling, poor memory and concentration, irritability of mood, poor response to hypnotic medication, and a lot of the medications just don't fix the sleep. They might fix the pain, or they might fix the mood, but they're not touching the sleep in a restorative way. Now, this is a 5-minute epoch of a sleep study in stage 2, and these interference patterns are the bursts of sympathetic drive that I'm talking about. And these bursts of sympathetic drive can go through any of the sleep stages. Now, with respect to the endocrine system and poor sleep, so if you think of a physiological stressor or a physical stressor or trauma, the sympathetic nervous system is in hyperdrive, the adrenaline's rushing, and they have these high output states. But if that carries on for long enough and there's non-restorative sleep, so this fragmentation of sleep with autonomic dysregulation happening over weeks, months, years, eventually they develop low normal levels whose cortisol is just flatlined throughout the whole day after having chronic sleep instability and insomnia. With that, they then develop the symptoms of adrenal fatigue. And this is a very good book that you might want to reference for your patients to understand this fatigue that plagues them in addition to their chronic pain, whether that pain be physical or emotional. They will get labeled, oh, you're depressed. You know, the doctor doesn't have the energy to keep on going. And you don't have the energy because A, you're not sleeping at night, so you're not putting gas in your gas tank, and B, your spark plugs are dead. So this is one thing that we need to look at, especially in chronic pain and chronic disease. Now, when I think about the sympathetic and parasympathetic nervous system, I'm thinking about fight, flight, or freeze. And that's really based on the polyvagal theory by Porges, which we will go into. And the parasympathetic system, I'm thinking of relax and restore. So my patients with PTSD, chronic pain, and insomnia, the first thing I talk about is your on system, your fight, flight, freeze is way up here, and your off, your relax and restore is nowhere to be found. We need to boost your relax and restore system. So I get them involved on the physical level with yoga, and if they can only do small pieces of restorative yoga or breathing or meditation, that's what they're doing. The other big useful tool that I've really, really come to appreciate is medical cannabis. We can use microdose CBD oil to help regulate this autonomic dysregulation so that their pain is well controlled throughout the day and their anxiety is well controlled throughout the day. And then at night, I can add CBD and THC to really help them get to sleep and stay asleep, but still maintaining that control of their pain and their anxiety. Eduardo Barnaroche is one of the few other sleep medicine specialists who also looks at sleep and stability. We look at it at SWAP because of Dr. Moldavsky. There is another man at Harvard, and then there's a specialty group in Italy. So there's very few sleep clinics that actually analyze our data for this sleep instability. And this Terzano et al., they're the Italian group, if you want to look at them. Very interesting research around epilepsy and other neurological issues and sleep. So this is Porges, and really, he's focusing on how the power of feeling safe allows you to connect your reptile brain to your limbic brain to your social brain, your frontal lobe. And if you are not feeling safe, you may either be stuck in the limbic brain or stuck in fight and flight mode. And so that was what's happening with my veterans. They were so stuck in fight and flight mode despite multiple medications, or they were completely zombified and they just couldn't even access that. They were so stuck in that mode, they couldn't go and do therapy. They couldn't go do physiotherapy because they'd have road rage on the way there. They couldn't go do talk therapy because they can't access the higher processing centers. So when they learn something, it just goes out the door because they're focusing on the reptile part of the brain, fight and flight. Everything is fight and flight. So what we found that by using the medical cannabis, I can take their brain, what I say is their brain from going 900 kilometers an hour down to 400 or 500 kilometers an hour so they can actually access these other higher cortical centers and start to process and heal. When we look at the polyvagal theory, we're really looking at nociception and the level of threat. So is it life-threatening? You know, dinosaurs coming along and you're a little turtle, you're going to freeze. That's the freeze response. Danger, you'll run, fight and flight. Safety, then you can engage in those social behaviors. The same thing, you can think of it almost like the lights. So you shut down when it's life-threatening. When there's danger, there's fight and flight, and there's safety, then there's social engagement. So you can even notice that when your patient walks into the examination room. How shut down are they? How activated are they? Are they able to actually engage in that higher cortical centers and have some quality of life, or are they still here in the fight and fight pain mode, whether that be physical, mental, or emotional? Now, in the trenches, I think this is a World War I I don't know what fronted that, but many of us have our fight and flight stress response triggered to greater or lesser extents throughout life. The PTSD is when it's stuck in that reptile part of the brain. And the problem with conventional treatments is that the antidepressants really don't access the idea of circuitry and the brain connections that is needed to look at the overconsolidation and the episodic retrieval of memories. So we need other modalities. CBT helps, EMDR helps, but if the brain is going 900 kilometers an hour, like I said, we need to find a way to bring that down. We need to find a way to upregulate the parasympathetic nervous system so they can be regulated enough to access healing. Now, in terms of the endocannabinoid system, the main receptors that have been looked at so far are CB1 and CB2, and you can see they're central and peripheral, as well as expressed on immune cells. These receptors are only two of potentially hundreds of receptors, because medical cannabis, a whole entourage effect of other components called terpenes. And each cannabis plant has its own specific profile. And therefore, different strains will help in different ways for different people's issues. The other thing about the endocannabinoid system is that it also acts on the G2 proteins. It's postsynaptic cell released. So you really have some flexibility in terms of neurotransmitter regulation and decreased cell excitability. So in patients who have this high sympathetic drive, it makes sense to use the medical cannabis. So the way I look at it is their minds are going 900 kilometers an hour, like I say. In your average civilian, whose brain is only going 300 or 400 kilometers an hour, if you give them cannabis, you're going to be taking them down to zero. So then you think of the amotivational part of the side effects that are talked about with medical cannabis. So really for me, when I see a patient, I'm looking at where is their autonomic nervous system tone set at. So what might work for someone who has slight pain and only moderate sleep issues will not be the same thing that I'm using on someone who's had chronic insomnia, severe back, knee, hip pain, and then other PTSD issues. And if you look at the receptor side so far for CB1 and CB2, the way I like to talk about medical cannabis is considering it as like almost the bridge from biochemical medicine to resetting the whole electromagnetic grid of the body, because those receptors are found throughout the body. And if we look at the endocannabinoid system in terms of its physiological processes, so it can increase appetite, help with nociception, vasodilation, cardiac function, motor control, memory and learning, immune and inflammatory response, and also neuroprotection. This actually can help the recovery of healing of neurons. They're also looking at using cannabis for extinction of memory so that you are not allowing the memory system to continuously run a feedback loop of the trauma, so that you are dampening that feedback loop so there's not consolidation of memories. Interestingly, Dr. Moldovsky had done some work in a retrospective analysis of over 14 years of military personnel, and he found that poor sleep quality predisposes to the development of PTSD independent of combat exposure. So what that says to me is that poor sleep quality even before combat means that autonomic nervous system was already primed, it was already hyped, there was already increased sympathetic tone, and then other stressors, whether it be the combat of war or physical injury, already will add to a state that was already preset for high sympathetic reactions. And the way I like to phrase it to the patients is that we're going to look at this boosting of your parasympathetic nervous system on a physical level, whereby they can engage in yoga, tai chi, swimming, mindfulness, enhanced cognitive behavioral therapy for insomnia. We can look at it on a biochemical level. We can look at it at the neuroelectromagnetic grid level. So that's looking at the PMS, the LILs, and some of the other interventions that you are using in your practices. We can look at the neuroemotional piece and then the psychosocial piece. So dealing with pain, as you know, complex chronic pain, we have to look at these levels. The same thing for the PTSD, the same thing with insomnia. These are not siloed issues. So overall, in treating my veterans, they've told me that their sleep has improved with medical cannabis from 1 to 4 hours to 4 to 6 hours a night. It's easier for them to fall asleep and stay asleep. They wake up feeling rested. They have improved energy levels. In terms of their PTSD and anxiety, I've been told it makes me much more tolerable guy. Before I was 0 to 100. I'm able to get out of the house. I get to enjoy my life again. It's helping them with memory and concentration, their ability to multitask. It's also helping with pain management and irritable bowel syndrome and greatly improved psychosocial functioning. Here's a sleep study of a veteran that we treated with medical cannabis. You can see there is very little deep sleep, which is a stage 3, and then REM itself is. These are the sympathetic bursts that are fragmenting the different parts of their sleep. So if he were sleeping normally, he'd be going down into deep sleep, then up into REM, down into deep sleep, up into REM, down into deep sleep, up into REM. So you know that he's already in an increased sympathetic state. After treatment for a year, it's not perfect, but we're getting towards having more episodes of deep sleep, as well as more periods of REM. And when we look at the actual sleep components, his sleep latency is improved, his sleep efficiency is improved, your decreased arousal, and wake after sleep onset has also diminished. Here's a case of a woman who's 72 years old. She was a horse-riding revolutionary woman. When I met her, she could barely move from her bedroom to her kitchen. And she said, this is no way to live. I live by the gun. I'm going to die by the gun. And these are the list of medications she was on at the time. And we really tried to work with her. We tried the LILT, which is the laser therapy. That was too prohibitive in terms of cost for her. Her son tried trial of cannabis, but unfortunately the licensed producer she went to gave her too high of THC and she had a bad trip. So they then came to see me and we were able to regulate with microdosing of CBD oil her pain management. And at night we used a 1-to-1 CBD THC to help with her insomnia and sleep fragmentation as well as pain. And now she's out, believe it or not, going to church, walking and interacting with friends and family. Her life is back. And I have many examples of this in the clinical practice that I would never have believed if I hadn't systematically been able to see these patients progress. And so the way I look at cannabis medicine, I see it that we do need more research, but we also need to be the consummate clinicians of the William Osler type, where we see our patients regularly and learn with them on how to best regulate their pain, their sleep, and their other issues. This is another case of a woman, very typical. You might recognize insomnia, history of snoring, daytime sleepiness, pain, neck, shoulders, back, feet. So when you have non-restorative sleep or insomnia for times, a lot of times the pain will initially start neck, shoulders, back, and feet. problems with concentration and depressed mood. So interestingly, we did the sleep study, and her apnea-hypopnea index, her sleep apnea was, her airway was closing completely or partially 23.8 times an hour. When we treated with CPAP, we were down below 5, which is in the normal range. And the REM events were actually down when we went and used the CPAP. And her sleep efficiency went down as well. Her oxygen was well controlled, so the CPAP was treating the sleep apnea. But you can also see her periodic arousals per hour were increased. So this means that she had a hyper-aware sympathetic drive that became disturbed by the mask on her face. So that type of patient might typically say, I can't wear the CPAP, because their autonomic nervous system is so dysregulated. So if we first treat the autonomic nervous system dysregulation and then try CPAP, we will likely have greater success. So these are the steps that we took in treating her. We dealt with her sleep hygiene, her exercise, her weight loss. We worked on desensitization of the mask so that you wear it only for an hour at a time, and then every week you can increase that to 2 or 3 hours as you're able. A lot of patients will become desensitized, disturbing feeling of the mask in about a month to a month and a half. So that is possible, but people with very severe pain, as you know, the last thing they want to do is go to bed with something on. So if we can better regulate the pain, stabilize the autonomic instability, then we can retry the CPAP. We also looked at her other sleep disorders and her comorbid medical psychiatric issues. She had a history of trauma. So that's another thing that you want to ask your patients is there a history of head trauma or motor vehicle accident? Even if they weren't knocked unconscious, they could have still had a concussion that is affecting their quality of sleep. And I will see it in a sleep study. I will see a reduced amount of deep sleep or REM, and also I will see a lot of that sleep instability with the microbursts of the sympathetic drive throughout. And the concussion could have been, or the accident could have been 20 years ago, and we still see it in the sleep study. So this again was her pattern. Here's another case of a 35-year-old with initial maintenance insomnia for 6 years. Sleeping pills don't work. Why don't the sleeping pills work? And they work initially to turn the brain off, but then the brain says, no, there's danger. I need to stay awake. I can't let this person fall asleep. We're in fight and flight mode. So the brain rewires itself around the medication. This is not a steady state. This is an ever-changing web of circuits that adapts to situations. And if it didn't, we'd be dead. Okay? So that's what we need to remember when we're treating our patients. What we started treating, and you know this with central sensitivity and other parts of medicine, is the patient we start with, we're doing the same medications over time, they might not be nearly as effective, or we're creating other issues that we need to look into. So with this patient, we looked at their sleep hygiene, their exercise, their weight, anything interfering with sleep, and this is something you want to check with your patients as well, the medications that are interfering with their sleep, or over-the-counters, Red Bulls, things like that, because you want them sleeping well, so that will help moderate their pain. She had medical disorders, psychiatric issues. She's a worrier, so when someone tells me a worrier, I know also they're anxious or hypervigilant during the day. For me, that's synonymous with insomnia at night, is that the nervous system is just on high alert. If it's high alert in the day, you can be sure they're not good sleepers at night. So we didn't need to treat her for obstructive sleep apnea, but we did do parasympathetic tone-enhancing activities. And we did give her some Remeron and some clonazepam. This was before I was treating with medical cannabis. And we looked at cyclobenzaprine to help as well with the sleep instability. That is another medication that helps with the non-restorative sleep patients. We looked at comorbid psychiatric issues, the history of trauma, and stressors. So this was her sleep study. When she first came to us, I'm not depressed, my mind won't turn off, I'm exhausted. So you can really see in terms of stage 3, there's very little stage 3. And then her REM sleep is only occurring towards the later parts of sleep. And you'll see that in many of the fibromyalgia patients, that they won't have the REM this part of the day. Their REM really starts to ramp up, and they'll catch up on their REM at 8, 9, 10 in the morning, just when they need to go to work, unfortunately. So this is later on, after going through our treatment program. She is having more REM, but we're still having a hard time getting the deep sleep for her. Now, the next modalities that I want to discuss with you are electromagnetic fields. We use electromagnetic fields in our investigations, MRIs, RTMS, I know they're using up on the hill with the schizophrenic patients, and it's being looked at for many neurological conditions. The pulse electromagnetic field therapy was developed in Russia. That's really where it was first developed and looked at for sports medicine. And it did very well in terms of treating chronic pain issues, as well as healing vascular problems. It's very good for the problems that you get with bone fusions and healings of wounds. But then they also found it was helping with depression and sleep. Now, why would that be? When I was treating the patients at Meditech International with their LILT, they have one of their technologies called BioFlex. We found that not only was the pain improving, our patients were reporting better quality sleep as well. And it's not only a function of decreasing the pain, it's also a function of decreasing the inflammatory factors in the body. When there are inflammatory factors in the body, it courses throughout the bloodstream, the brain can say, oh, there's inflammation. I better stay awake. I better stay on guard. So whenever you have a process that increases inflammation in the body, like even rheumatological disorders or IBS or Crohn's, those inflammatory factors are also going to affect the sleep quality of your patient. Now, PMS is a pulse waveform that can come in different frequencies. And the different frequencies that you adjust the PMS to depend on what your target treatment is. A big component of PMS is that it triggers the inflammatory, dampen the inflammatory cascades, and also dampens oxidative stress. So again, that you can see where that would play a role in the mechanism of pain management. It also helps increase the production of ATP. So PMS therapy improves pain management, reduces inflammation and edema. It enhances capillary formation and microcirculation. So not only are we bringing down inflammation, we're actually enhancing circulation to areas of tissue that need to be healed. Faster functional recovery, reduces muscle loss after surgery, increases tensile strength of ligaments. It also can promote the regeneration of collagen. It accelerates nerve regeneration and reduces tissue necrosis. So with diabetic neuropathy and some of our gangrenous feet, we've been able to actually save toes from being amputated using a PMF and LILT. This is what the PMF system looks like that I use. It's this blue mat. It's not much thicker than a yoga mat, and it has Tesla coils. It's made of Tesla coils throughout the mat, and we can run over 1 million different electromagnetic frequency signatures for the patient. We have standard signatures for microcirculation, neuroregeneration, and balancing the autonomic nervous system, but we can also, once we've stabilize the autonomic nervous system, the next step is we customize a person's treatment protocol. So what they do is they lie on the mat and we run up to 1 million frequencies over the computer, and the computer finds the top 9 frequencies that resonate with where their body's electromagnetic grid is currently to heal those 9 frequencies of dis-ease. They use their personalized card at home. The protocols run for about 36 minutes each. You use them every second day so that you don't get habituation. And once we've healed those levels of inflammation or pain, we can again run another diagnostic protocol and find out what the next 9 frequencies that the body needs to heal, what the cells need to heal. So our cells are not only biochemical soups, they are actually responding to electromagnetic frequencies. And if you think of across the cell membrane the charge that needs to be maintained, you can look at Dr. Tanner. I just was watching his YouTube videos last night. He's saying that disease occurs when the frequency of the cell deteriorates. So if you want to maintain health and move your patients towards health, one way of looking at it beyond the biochemical model is looking at it at the frequency bioenergetic model. And this is just something that you can review that's in the slide handouts that I went over, and all the different ways in which EMF can improve a recovery from spinal cord injury, and the therapeutic effects that have been looked at so far in published papers in terms of acute pain and osteoporosis. The other thing is PMF, it can be a cost-effective tool. Once the patient has purchased their own bed or has access to one of the mats, they can be run over and over again and be used in multiple ways for themselves and also later on for other family members who come for diagnostics in terms of what frequencies they need for their issues. This is again an example how the EMF can help with cartilage and bone regeneration, help with decreased inflammation. And I have an example of a 46-year-old ex-professional hockey player with multiple concussions. We're querying CTE, so chronic traumatic encephalopathy, that is became very big with a movie that was out a few years ago. He's had a sudden change that has just worsened over the last 6 years of increased anxiety and anger outbursts and hypervigilance and paranoia. And really, medications that his doctors have tried to use haven't been a benefit. He's tried medical cannabis, and that has had issues as well. So now the next step that we are attempting is to really help try as well, in combination with the other modalities, to see if we can get his brain to slow down. So you can see all the sympathetic bursts that are happening in this man's sleep study. He just came to me 2 weeks ago. So it's a work in progress, but I just wanted to share that with you. No deep sleep whatsoever. And he's just on sympathetic overdrive, nonstop, running. And what we're looking at him is targeting the inflammation in his system. We're targeting the ANS dysregulation. We want to target his physical pain, and we also want to target his mood and anxiety issues. And the beauty with the PMF is we can use the anti-inflammatory treatment protocol, we can use a neurorelaxation protocol, we can use a microcirculation protocol, and then we can use a neurodegeneration of fibronactin protocol. These are all different frequency signatures that can help him heal in different ways. Low intensity laser, it can also help with angiogenesis, collagen formation, muscle atrophy, regeneration, inflammatory and edema, nerve regeneration, which is very interesting in terms of helping with diabetic neuropathy and other neurological cartilage production and bone formation and healing. Really, this was further developed, like I said, in Russia, but the father of laser therapy was really Andrei Mester, and he noticed that he was using on rats, and he was wondering if the laser did not kill the tumor cells, but the laser did enhance healing of the incision and hair growth on the rats and mice he was working with. And so he coined the term photobiomodulation. And with that, researchers have gone on to find out which exact frequencies are beneficial, because laser can cut through tissue, like we use laser in surgery, but we can also use it to enhance the functioning of cells. Lilt uses wavelengths between 632 and 1064, and it helps stimulate biological responses. So the way I see it is, we give energy to the cells and to our body systems so they can start their innate healing processes. And that's how I explain it to the patients. The laser doesn't emit any heat, doesn't emit any sound, doesn't emit any vibration, but if you're using it close to the face, you must have the eyes covered to protect vision. Dr. Khan at the Meditech International has now also started using laser for treating post-concussion syndrome and some of the neurological diseases such as Parkinson's, and treatment over 3 to 4 to 5, 6 months does show some clinical progress in these areas. And it's more research that needs to be done, but definitely we're seeing improvements that weren't seen with the use of medications. The thing with the laser is that it allows you to enhance again the web of connections that we talked about earlier. I have a patient here who was a 28-year-old banker, fainted while taking the subway and forcibly struck at the back of her head, lost consciousness. She was examined. He was examined in the ER, followed with MRI and neurological consultation. You've got post-concussion syndrome, hello, goodbye. Many of our patients are suffering with this. And then the headaches were severe, like sensitivity, brain fogginess, ability to concentrate, pain in the cervical area with decreased range of motion. And so medications were trialed before other modalities were trialed, but this 28-year-old wasn't moving very far ahead. So they were treated 3 times in 6 months with the BioFlex laser system. And these are looking at this patient's cognitive symptoms over time. So you can see how the fatigue and the drowsiness responded very well to the laser therapy in the early periods, and then we have a drop-off of some of the other symptoms. Really, the mental fogginess is a function of the web of connections of the brain, but it's also a function of bringing down the inflammatory factors systemically and also within the brain itself. Her somatic symptoms also dropped. The big one is the headache and the sensitivity to light. So I see it as actually the same way you recharge a cell phone. We're recharging the electromagnetic grid of the body, the electrical circuits, so that they can function once again. Her cognitive symptoms were improved. And a lot of this work, if you want to look at some of the very cutting edge work around neuroplasticity, I suggest looking into Norman Deutsch's The Brain's Way of Healing. And it's not only looking at the brain, it's also looking at pain and other neurological issues. And he's gone around the world looking for people who are doing the most cutting edge neuroscience work that has yet to be trickled down into our universities and education for our doctors. In terms of just leaving you with some clinical pearls, the way I deal with insomnia with my patients, I say, how long does it take you to fall asleep at night? So how long should it take a person to fall asleep? Maybe 15, 30 minutes. When you get over 1 hour, that's initial insomnia. If it's been carrying on for more than a month, that's initial insomnia. Maintenance insomnia is how many times you wake up in the night. 4, 5, 6 times. I don't know, doctor, I get up to pee. They think they're getting up to pee, but it's actually the sympathetic arousal bursts that are waking them up, which also produce more urine. And then so you know that there's autonomic instability at night. In terms of terminal insomnia, do you wake up earlier than expected? That's the people waking up at 4 or 5 in the morning. And likelihood is if you were to do a cortisol analysis over 24 hours, you'd see that's when they have their cortisol bursts, rather than the healthier patient that would have that cortisol surge just as you're getting up at 6, 7, 8, 9, they're having it at 2, 3, 4 in the morning instead of what it's supposed to be. Non-restorative sleep, very easy question. Do you feel refreshed when you wake up in the morning? And when's the last time you remember waking up feeling refreshed? So people here in the audience, when's the last time you remember waking up feeling refreshed? Or who wakes up refreshed every morning? Good for you.
I'm retired.
You're retired, okay. Regular exercise helps in terms of buffering against autonomic dysregulation, and I talk about on exercises and off exercises. So you might have an insomniac, and they said, well, my doctor told me to go exercise, so they go do the gym, they go do cardio. But what that's doing, that's only potentiating the sympathetic nervous system. So I tell those patients, well, I need you not to do on exercises, I need you to do off, things that boost the parasympathetic nervous system. So that's the yoga, tai chi, swimming, and meditation. What do you think they say to me? That's too slow. I get really irritated with that. I said, that's exactly why you need it. Your car has no brakes. And what happens to a machine that has no brakes? Crash, pain gets worse, and then cognitive abilities get worse. So your ability to function and be productive at work is compromised. So it makes sense to invest in off. I call it the wisdom of off. Not the power of now, it's the wisdom of off. So again, we talked about sleepiness versus fatigue. So do you have the urge to fall asleep during the day? Are you sitting in the car, watching TV? Or are you exhausted all the time? So they'll say to you, doctor, I'm exhausted, I'm in pain, but I just can't turn off. That's when you know their autonomic nervous system is just dysregulated. Their on-off switch is not working properly. Duration is always interesting to me because the longer the insomnia has been, the more chronic it is, the harder it is to treat. And this sleep instability is also genetic as well. So if you had parents who had this autonomic dysregulation, chances are you're going to have it as well, and then you have environmental factors that make it worse. So why do we have this autonomic burst anyways, the sympathetic burst? Well, some of the researchers posit that when we were living in jungles and forests, we would just naturally wake up, scan the environment for a predator, and then go back to sleep. So what happened to those animals that didn't? They just slept. They were eaten, they're gone. So in fact, it's your brain trying to protect you from danger, but it's happening in a context where there is no danger. So I can ask my patients, did your mother have to drag you out of bed for grade school? Was it high school? Was it university? Many people with university, with the increased stresses of university. Other people with grade 9, but there are people who were colicky babies, so you know already their second brain, their gut was dysregulated, their brain was dysregulated from the time they came out of the womb. And if you find out about their history in utero and their mother was under incredible stress, they showed this with rat in my studies that if the mother in utero is under stress, she's releasing cortisol that is already priming the fetus's brain for fight and flight. And you can also then extrapolate that to nociception as well too. So they're primed and ready to go for chronic insomnia and chronic pain and PTSD. Cognitive impairment. Are you having, to what extent are your sleep problems affecting your ability to function at work? Many of my patients with the chronic pain and in insomnia say, doctor, I go to work, come home and crash, I have no social life left. So they become increasingly isolated, and I'm sure you've seen this with your patients as well. As my patients recover from the autonomic instability and we decrease the inflammation in their body through medical cannabis or laser or PMF, there's one IBM patient programmer that stands out of my mind who goes, I can read journals again. So this is someone who is a high functioning person who went from sleep study clinic to sleep clinic, and they said, oh, no, it's all in your head. You know, you've got depression. I call the raw data. He had no deep sleep and reduced REM, but he didn't have sleep apnea, so his sleep was all right. So you need to see the raw data, and I said, look, it's all here. We need to boost your parasympathetic nervous system. So when he got to the point where he could read his scientific journals again, he felt, wow, it wasn't just me being lazy. I actually did have something going on in my brain that wasn't allowing it to recharge properly. Psychological impairments, you can ask them about irritability of mood, anxiety, accidents at play, at work, and driving. People who are sleep deprived have accidents. And so that's the other thing we need to be careful of. Are they working in jobs that would be dangerous, like truck drivers or other areas that we have a duty to report if it becomes very impairing? And then we can ask them about the chronic illness and chronic pain, and how does pain affect their sleep, their illness, the quality of their sleep affect their pain and illness, and see what they've noticed. I was really fascinated when I first started treating the veterans with medical cannabis, you know, and I called them up and I said, well, how has medical cannabis helped you? And I would expect the first one, their answer would be, it's helped my pain. I don't have nightmares, I don't have flashbacks. 90% approximately say sleep. And that's how many of them were against medical cannabis because it was illegal in the military. They said, well, I wouldn't do that, but, you know, it was a party and my buddy passed me a slip, and I slept for the first time in 15 years. And they're telling me what's happening is when we treat with the medical cannabis or with the TMS or we get them on the BioFlex, they're going from fragmented sleep where they're waking up every 1 to 2 hours to a deeper sleep of a solid 4 to 5 hours. We're not getting 8 hours, but we're getting solid 4 to 5 hours. And that is making a big difference in their daytime functioning as well. So at this point, I'll go over with you just another few aspects that I want to highlight. So insomnia and stress have medical, psychological, cognitive, and occupational consequences. Sleep, chronic pain, and mental disorders have really, you got to look at them as in a triangle. Traditionally, sleep is like kind of relegated to, oh, that's just a byproduct of the chronic illness, oh, that's just a byproduct of depression. But sleep issues, disorders of sleep, is an entity unto itself, which is affecting the psychological issue or the physical pain issue. So there are really three entities that need to be looked at in considering your patient. So I want you to also keep in mind the chronic insomnia and the signs of significant ANS dysregulation. And significant autonomic nervous system dysregulation, when they come to me, they've been to 2 or 3 sleep clinics, they've been to neurologists, they've been to pain management clinics, and really many of the medications haven't worked. And they were dosed higher and higher and higher. To what effect? Side effects. So I have stories from veterans who've lost 8, 10 years of their lives literally drooling on the couch from excess opioids, sending in some benzos with that. They were handed out like candies. It's some antidepressants. The Effexor is really not very good for sleep at all. Once you dose it higher than 75 milligrams at night, it helps with boost the energy and helps with mood, but dose higher than that, you start to fragment sleep. SNRI medications also fragment sleep and suppress REM. So these are things that need to be thought about and discussed with patients. But now my veterans, from going from being stuck in their basement literally for 8-10 years, drooling on the they're out functioning in the world again, using these modalities that we're using, and most of them are off their medications. We've discontinued. I stabilize them on the cannabis. I get the pain even more controlled, enhanced pain control with the PMF and the lilt, and then they're off their pain medications, they're off the antidepressants, they're happy because their libido is back, they are out, their anxiety is controlled so they can actually go out in public more easily. They can actually, one veteran said to me, he says, "Doctor, I had my first dinner with my family for the first time in 5 years. I actually went Christmas shopping." And then unfortunately, when the government cut down their level of medical cannabis, many of them went from dosing 8 grams a day down to 3. They were once again locked in their homes. The pain came back, the anxiety came back, and even some lost wives and lost their lives because they went back into that dark hole where they had been sitting for 6-8 years in polypharmacy. And they tell me, "Doctor, I can't go back to the pills. I really can't go back to the pills. Anything but go back to the pills." Treatments with enhanced parasympathetic nervous system tone, reduce inflammation, and stimulate angiogenesis. I really like the idea of being able to bring fresh blood supply to damaged tissue. Of many drugs that actually can help decrease the inflammatory responses as well too, as effectively. I mean, we have prednisone, but then we have many side effects of that, right? So these are interesting modalities that I think that if you were interested, you're more than welcome to come to SWAP and observe them, or I can point you to other doctors who are using these modalities. And many of them aren't doctors, many of them are chiropractors using these modalities. Many of them are nurse practitioners using these modalities. Unfortunately, they're not being adopted in the medical system, and that's partly due to treatment guidelines and need for more research. But I've always been driven on how can I help the patient in front of me, and what do I need to learn next to help them further. So I agree that we need to have research and answer questions, but that research and answer questions need to be informed also by what we're learning from the patients. And here's a summary looking at all of the importance of sleep, the endocannabinoid system, and the PMF, as well as the physiological clinical effects of lilt. And you can see there's crossovers for many of these modalities. And I say thank you. And I really do this work to help keep humanity humane. I've been to Ottawa to speak at their Special Committee for Veteran Affairs. I've been to many other places saying that we need to continue to push science forward and medicine forward and not be stuck with our old paradigms that do help in some situations but are falling short of the mark in many complex situations.
Thank you very much. I'm a little bit past the have to get to another meeting, but I would like to ask a question, which is how do you measure autonomic nervous system regulation? So when you say it's dysregulated, are you doing that with the EEG monitoring?
Yes, the EEG monitoring. Yeah. Well, we have the EEG monitoring and we have the heart rate variability, but there are also there's a really good bracelet out of MIT that we're looking at getting into the lab as well too, which will monitor the autonomic nervous system 24 hours a day on my veterans. So we're trying to get more sophisticated, but it is the heart rate variability and the EEG. Yeah.
Sorry, someone else may ask a question. Sorry, macro first and then.
Yes, I'm wondering about this laser therapy.
Mm-hmm.
How do you apply laser radiation to certain areas in the brain?
Mm-hmm. Yeah, it's on. There's a grid. It's on a pad, and you put the pad on the head, and you the specific frequencies that have been found through research to benefit the brain or whatever area or issue that you're trying to deal with. If you want to Google Meditech International or Bioplex, they're one of the foremost clinics working with LILT, and people travel from around the world to get treatment in that clinic. You can speak with their clinicians there and really have them walk you through the treatment modality, or even go and observe. Their clinicians are there on Wednesdays. But really, seeing is believing. I never would have believed the improvement in pain management and in function that I saw in the patients when I first started there 3 years ago. Like, we weren't taught this in medical school.
So the bone and the skull
Yes.
does not stop the laser radiation?
Well, there are specific areas that are more permeable throughout the skull. So the blood-brain barriers, if you want to target that, you're targeting these parts of the skull, and then where the fontanelles would have been, that part of the skull is also thinner. So those are some of the areas that we actually focus on sending the treatment through.
Thank you.
Very good for TMJ. We have people with intractable TMJ who they've gone everywhere, and we're able to help give them relief. And there's even home units they can take home and treat themselves with.
I remember you talking to a neurosurgeon, just drills holes.
Thank you for the nice talk. My question regarding the pulse electromagnetic field.
Yeah.
Is it the same of the scrambler therapy, or is it different?
I'm not familiar with scrambler therapy, sorry. So.
Italian group
Okay.
a few years ago had the device approved to be used in neuropathic pain in a cancer patient,
Mm-hmm.
the chemotherapy induced, and they
Yes.
put like an ECG pad
Yes.
over the body, then they connect the electricity,
Yeah.
and so I don't know, it's the
So
same.
it's the same concept in terms of altering the electromagnetic field within the electrical grid of the body to help. Sounds like it's a similar concept, but I'm not familiar with that technology. But really, what we need to open our minds to is we need to go beyond biochemical medicine into electromagnetic grid medicine.
Great. Thanks again. Thanks very much.